And thank you very much for joining us here on PM Express. Tonight, around the world, this conversation is dominating discussions in the corridors of power, from Washington to London to Paris and to Accra. The roadmap to lifting restrictions. Governments and presidents across the world are currently planning and thinking through this. Yesterday, our president gave us the strongest indication yet that Ghana is on the path as well of figuring out what it would take and what the roadmap should be to lifting the restrictions left in place. And that's what we're going to be looking at tonight from a scientific point of view, especially on the back of the surge in COVID-19 cases. And the reality is in the numbers. 4,700 cases, as you know, 494 recoveries, and 22 deaths. Significant hikes in the numbers of infections there. If you look at the regional balance, Greater Accra is still a major hotspot. I mean, 3,800. It's by far the hottest in terms of the spots where coronavirus infections have been found compared to the rest of the regions. Ashanti 355 and the Central Region 127, and Eastern as well. And if you look at the other regions, really, they all pale in comparison to what we're seeing in the nation's capital. The question really to ask ourselves is, why are we seeing these high cases in Greater Accra? Is it that because we're simply testing more in Accra and testing less in other parts of the country? We don't know yet. Is the representation of the cases in the other regions a factor of how much testing we are doing? And some are calling for more testing across the country. And if you look at the concerns that have been expressed so far, I mean, the surge, the significant cases that we've seen, of course, is raising concerns about the restrictions that were lifted some time back by the president. The Ghana Health Service assertion that, you know, Ghana's COVID-19 curve has peaked in itself has generated a fair measure of controversy. We'll look into that and how that feeds into going forward and what we have to do before we could lift the rest of the restrictions, especially on gatherings in this country. We know this is a pretty worrying statistic here. The 533 cases that we got as part of our case count from one single factory. In Tema, the president told us that yesterday. We're also hearing of the complete disregard for social distancing, one of the key things to slow down the spread. The Ghana Medical Association has also warned the president not to lift the ban on public gatherings. Going into yesterday's national address, the president, of course, kept to his guns and didn't lift it. But for how long? We know these restrictions have been put in place up until the end of May. Beyond May, what do we have to see scientifically and data-wise at the end of May for us to make a decision as a country whether to lift the rest of the restrictions? And that's the conversation we have it. I mean, we know the president's, that's the 31st of May. So we have, what, just over 2 more weeks before this is reviewed. It's also a key thing. He gave us a firm indication yesterday about this roadmap. We don't know what this roadmap is going to look like, but we are learning from other parts of the world. And so we can fairly analyze what it should look like and what the Ghana-specific peculiar case will be. You want to stay with us for that. And so we'll be looking at that and also assessing what the president said just yesterday and what that most importantly means for you. People want to plan with their lives, okay? I mean, and we need to follow the statistics and speak to the experts so we also understand what is happening. And that's why we're going to be doing this for the parents, the businesses, the people who are home wondering what it will take for these restrictions that remain, particularly on gatherings, to be lifted. The experts are joining me on the show after the break to break it down for you. Stay with us. Thank you very much for joining us here on PM Express. My guest joining me for tonight's discussion, Dr. Angelina Augustina Angelina Silver King joins us tonight via Zoom. She is a research scientist. Also, she is a virologist with the KCCL and the KNUST, a lecturer in theoretical applied biology there as well. Also joining me tonight is Professor MARGARET, who is the public health expert and former dean of School of Public Health at UHAS, also joining me on Zoom tonight. I'm also delighted to be speaking tonight via Zoom to Dr. Bertha Ayi. Of course, you know her. She has been on the show a few times from the United States, specialist in clinical infectious diseases and an adjunct assistant prof of medicine, Kansas Health Science Center. And I'm delighted that we could also have Dr. BEDIAKO, who was on the show when we did the myth-busting conversation. I really enjoyed that conversation because he taught me a lot. He's a research fellow, West Africa Center for Cell Biology, and of course, infectious pathogens. I'm grateful, ladies and gentlemen, for joining me here on PM Express. I want to start by getting your thoughts on what the data we have currently is telling you. Yesterday, we got an update from the president. The Ghana Health Service pages have since been updated to reflect that. Dr. BEDIAKO, when you listen to the president as he laid out the statistics for us, what did that tell you as in where we are with our coronavirus fight?
Thank you. Thank you for having me. It's good to be back. I think as the president gave his update on the numbers, I think it's clear that the coronavirus fight is not over. I think in many ways for Ghana, we are really just beginning to get into the thick of things. I think what struck me was that despite, I'll say the apparent drop in number of cases, actually, if you look at the proportion of tests that are positive, we appear to be on a rise. So I think based on what the figures the president talked about, you had, I think the last number he mentioned, you had about 5% of the tests that were done that day were positive, which is quite a significant increase from the 1 to 2% that we were seeing earlier on. So it suggests that the virus is expanding. Obviously, we heard the report of the factory in Tema where you had that outbreak. I think it shows what can happen with this virus if measures are not taken. So I think in general, I felt we are at I wouldn't quite call it a crossroads, but we are at a point as a country where we are going to begin to really grapple with this virus. Thankfully, our deaths still remain relatively low compared to other parts of the world. We can be thankful for that. But I think we are going to have to think very carefully about how we go forward, how we try to mitigate the spread of this virus. And we are going to have to follow very closely the mortality and the disease associated with this.
I want to bring in Dr. Bertha Ayi. Doc, there's a lot of conversation around which indications are most important in looking at a country's status in terms of your fight against coronavirus. Last week I was watching the UK presentation, and they are relying heavily on something they call the R. I wonder what that is. I think the rate of infections, something to that effect. You can explain that for me. That's what they are relying on quite heavily. What is, in your view, what is the most appropriate statistic or data set that, I guess, gives you a better indication of where you are as a country in your fight against the virus?
Thank you very much, and thank you for having me on your program. So the R they were talking about is what is called a reproductive number. And just generally across the world, the reproductive number for this outbreak has been thought to be between 2.5 to 3. And what the R means is the number of people who can get infected from one infected individual, specifically in a non-immune, non-vaccinated population. So COVID-19 provides the quintessential example of your real measurement of R, meaning nobody is immune to this disease and nobody has been vaccinated. So on average, one person during the course of their infection is expected to transmit to 3 people. And in some parts of like we have somebody they call the Chicago spreader, was able to transmit to 16 people. We have one attorney in the state of New York, New Rochelle, who transmitted to 100 people within 1 week. And then we have the churchgoer in South Korea, who was supposed to have transmitted to 1,100 people. And so it all depends. The 3 is dependent on your average day-to-day activity. But then when you have an overcrowded setting like that factory where there are lots of people around one infected individual, you can have a large number of people getting infected. So the UK Prime Minister's address was referring to an R. But the World Health Organization has come out with a set of 6 criteria that need to be followed. And maybe the best way to explain it is to use the analogy of the noisome pestilence that Psalm 91 verse 3 talks about. So let's take it that the outbreak is a noise. And then imagine the quiet of the night when you don't have any noise and there's no activity. So the first thing is that for you to start taking down your lockdown measures, you need to ensure that you believe that you don't even have active transmission. So that the night is quiet and there's no noise. Secondly, you should be able to pick up as soon as you have a case, you should be able to pick it up. So back to the noise analogy, it should be so quiet that as soon as somebody blows a whistle or there's any noise, any member in your population should be able to say, oh my God, there's noise. So you should be able to detect every new case and every infection. And then you also have to be able to engage your population. So let me use smallpox as an example. When smallpox was getting eradicated, which by the way took over 3,000 years, the last patient was a child from Bangladesh, a 3-year-old. And do you know the age of the person who informed authorities? It was an 8-year-old girl who informed the local smallpox eradication team that she believes that there's a 3-year-old in a certain house that was infected. So the team went there, they identified the patient, they put law enforcement outside the house, they vaccinated everybody within 5 miles, and that was the last known case of smallpox major. So it tells you how an engaged population, people who understand and are fully aware of an infection, is very necessary in beginning to say that we're taking down lockdown measures. And finally, you have to have the ability to take care of your cases and be able to test very well. So these are the criteria that the World Health Organization has laid out. So first, your R0 has to be 1, meaning that you have to be sure that you don't have a situation where one person is given to 3 to 9, 9 to 27, but you're only getting 1 person to 1. Because when you have an R0 of 1, you cannot have an outbreak. It's flat. That's when you say your curve is flat. So those are the criteria that we need to look at. I hope my analogy has helped you understand it somewhat.
I do. Thank you very much. I want to bring in Professor KWEKU. So, Prof, when we hear the president point to our low death rate, I mean, compared to others, and the infection rate, and they point to that and say we're doing very well, and so they, in essence, shouldn't be an alarm. And I've heard the president quite emphasize those who have died are those who have underlying health condition. I wonder whether those indicators that he uses, and again, if you look at the 22 deaths, really small compared to what we're seeing elsewhere, thousands. In the US, we are 70,000 plus. Does it indicate, and if you look at the statistics generally, does it indicate where we are right now, that we are better off today in our fight against coronavirus or worse off? What does it tell you?
Thank you very much. I think we as a country having low death doesn't mean that we are doing very well or we are better than other countries. We need to look at our population structure. In developed countries where death is very high, you see that the death occurs mostly among the aged, those above 60 years. But in our country, the death is occurring among all age groups. If we look at our population pyramid and compare that to that of the developed countries, we have a very broad-based population pyramid where the peak, the tip is small, which means the aged group is very small in our country compared to the developed world where the base is thin and the peak is very broad. Therefore, if the disease is affecting the aged who have underlying causes or diseases, it will affect those people more. It doesn't mean in developed countries the younger age groups are not being affected, but the aged have overshadowed them. In our country, it is proving to us that we don't have that aged group. We die before 80 years. Most of us die before 80, 70 years. So we are not seeing that high death rate in our country. However, it is affecting the younger age group who also have underlying diseases. So we need to look at it in our context, that in our country, it is affecting the younger age group. We are only lucky they are not dying like other countries. However, they are the workforce. And if they have to be bedridden for a long time, it will affect our economy more than the developed countries.
Perspective there. I want to bring in Dr. Silva King. So, Doc, so when the president yesterday said, quote, the rapid implementation of our policies has resulted in a low infection, hospitalization, and death rates, some of the lowest in Africa and the world. We certainly must be doing something right in Ghana. You agree?
Good evening, Sams, and good evening to your cherished listeners and viewers. Indeed, I think we are really doing something right, and I have wondered whether the virus is sort of being a bit kind on Africans. Of course, in Ghana, we had a lot of policies in terms of testing, so we were interested in doing an aggressive testing, an aggressive contact tracing. So the plan over here is that you go into communities, you go into affected populations, for example, and then you try and pull them out and manage them as well as trace their contact. And I think we did very, very well, so that when you even look at the proportions in terms of those who have we have lost, died, we are doing around 0.5, which is very low. But then in terms of our recovery rates, maybe we still have a long way to go. But of course, you can be doing this aggressive testing and aggressive contact tracing, but there's always a limit to which you can go to. So, for example, you need to invest in resources, you need to purchase logistics, and unfortunately for us, most of these logistics are such that we can't even produce them in country. And the amazing thing is that if you want to, even if you have the money and you want to purchase them from outside, they themselves need those logistics. So we may have all the nice policies, but at a point in time, we may want to re-strategize. We may want to have a second look at the policies regarding testing, regarding all the things we want to do to curb the spread of this particular virus. I
mean, Dr. KWEKU, I want to come back to you. You made the point about that. Would you put the low infection rate, low hospitalization, low death rates that the president talks about, would you put it down to the measures that we are implementing? Or this is just a factor of something else at play here that we probably haven't put our pulse on yet? Hello, Dr. KWEKU.
Hello?
Yes, can you hear me?
Yes, I can hear you.
Yes, I was asking you, the low infection, low hospitalization, low death rates that the president talks of. I'm just wondering, what would you put it down to? The president put it down to the policies that we're implementing, as in the aggressive, proactive, going into a community and looking for people and testing them? Or is something else that is at play here?
I think currently what we have done so far has helped us a lot. Mm-hmm. We have done aggressive testing. We have done enough contact tracing, and we got the cases. And that's why we managed to get all those cases which we have recorded. Mm-hmm. And then we have tested the backlog. Now, what I have to say at this point is that having done all these things, we have managed to clear the backlog. Mm-hmm. And we are yet to actually see the actual cases that are occurring on daily basis. For now, we can't tell because it is only 2 or 3 days back that we finished clearing the backlog, which means we were mixing the cases, the new cases with the backlog. We have done well so far, and I think we now have to start the real work, where we will now look for the cases and not backlog, and we have to ensure that every case is tested. And how do we do that? We need to have logistics. We need to get the people in the communities aware and report. All these things have to be done so that we ensure that everybody is contributing. For the death rate, as I said, we don't have the aged group as other countries. But for the infection, if we do contact tracing and we get them and test them, they are not seriously ill. So we are getting cases which are not severe and bedridden. But now we have cleared those ones. What do we do next? We need to put plans in place so that we know how to capture all the cases. Yeah. Right now, like what the president said, in one factory, we are getting about 500 plus. Yeah. Measures need to be put in place, which means all the measures being put in place, most people are not following them. What do we do for Ghanaians to follow and ensure that these measures are enforced?
I want to bring in Dr. BEDIAKO. And Doc, tell me this. Your outfit did this groundbreaking work in Ghana where you sequenced the genes of the virus. Correct me if I'm right. That's what you did, right?
Yes.
And then you found that what we have locally is similar to what is elsewhere in China and other countries, correct?
Yes. I mean, what we found was we sequenced 15 isolates that were isolates from individuals who were in Ghana. It was a mixture of people who had recently traveled out of from other parts of the world into the country, and a number of people who had no history of travel.
Yeah, I mean, my question is, if that is the case and you found the evidence you found, how come if we're having similar, I guess, traits of the virus in Ghana, these countries where I guess we imported it from are having very high death, mortality rates, infection rates, compared to what we have locally, which is really negligible compared to what these other countries have. What's happening here?
I mean, we still don't fully understand. I think, one of your panelists, like Dr. Silverkin said, that we are thankful that the virus so far is treating us more kindly. But I think, as Prof herself has mentioned, we have very different population structure. Mm-hmm. And so we cannot necessarily expect the virus to behave exactly the way it has behaved elsewhere here. What I would caution is our outbreak is also younger. So as you know, the virus came here from somewhere else, and it got to Africa later than everywhere else. The first case in Ghana was 12th of March. There were cases in China end of last year. There were cases in the US in January of this year. So our outbreak is younger. And so we are behind in terms of, we can't compare ourselves directly to what's happening in other countries because the virus has been there longer. Having said that, yes, the viruses we sequenced, once again, that was several weeks ago now, looked a lot like virus that had come from other parts of the world. We had some that looked like Chinese, we had some that looked like European or American. And it appears all the sequencing data out there suggests that this virus thankfully mutates rather slowly. Having said that, if we're talking about steps to move forward, we desperately need to ramp up our sequencing. It is possible that in the subsequent weeks, as our own outbreak has grown and has been continued to be transmitted within our country, within our population, it is possible that the virus has continued to mutate. So it's possible that if we were to compare the sequences of viruses that we get right now with the viruses that we sequenced several weeks ago, there could be some differences. Now, I will also add, sorry, before you come in, also add that if we're talking about the difference between how the disease looks here and elsewhere, one thing that we have to talk about is the asymptomatic cases. We appear to have a lot of people who are asymptomatic, perhaps even more than in other parts of the world. Now, that is, on the one hand, a very good thing because it means people are not very sick. On the other hand, it means identifying cases is even more difficult. Like Dr. Bertha was saying about smallpox. With smallpox, it's pretty obvious that somebody has smallpox because they break out into a rash. With this, if the people are asymptomatic, we have no idea that they are positive. They are walking around looking healthy, and they are potentially spreading. So we have a challenge where, because the virus is not being as deadly currently, we are more likely actually to spread it unknowingly. And it could spread into populations who are vulnerable. So we do have people with underlying conditions. Just we have a younger population, so perhaps we haven't had the immediate deaths that we have seen. But there is no guarantee that as the virus continues to spread to our population, we will not begin to acquire more deaths as the virus moves into more and more vulnerable populations within our country. So I think the challenge we have really is identifying cases, because a lot of our people are infected but are asymptomatic. And the challenge I think we have, unlike most countries who have been ramping up their testing capacity, we have sort of invested heavily in our mass testing, and now we're sort of tailoring down. I mean, I understand the economic considerations, but the thing we have to now think about is, whereas most countries are pushing to test more and more people as their outbreak continues, Ghana has actually tested a lot of people and is now testing fewer people. Now, we need to start asking ourselves, if we cannot test as many people as we did before, are we at least testing strategically? And I think that's where we probably want to go into.
Okay, so that's a final point I'll come to explore. But there's a point you raised that I want to get my other guests to weigh in on, which is the fact that we are relatively younger in terms of our outbreak compared to the other countries. I want to bring you in, Dr. Silver King, on that. Because how do you reconcile that? The point that Dr. BEDIAKO makes about the relativity in terms of where we are in terms of our outbreak compared to the other countries where our viruses came from. How do you reconcile that with the assertion by the Ghana Health Service last week that we have peaked already and are on the decline? I mean, how do you reconcile that? Because I'm thinking, if we have peaked, and then obviously the worst is over, I guess. That's what it means in layman's terms. And if you take Dr. BEDIAKO's point that we are, young in terms of the outbreak, that tells me that possibly we may get to a point where we may hit, worse numbers than we currently have. Give me a sense of how you balance the two points.
Indeed, and we know that we haven't peaked. And over the weekend, I heard something quite interesting. Somebody passed their comments that if we peaked already, then we are really yet to peak. We know that we haven't yet peaked. If you look at countries like Italy, China, US, and the likes. Once you peak, you would really know that you have peaked. So your health systems will definitely be overwhelmed, and people will be rushing all over. They will require ICU management, and we know that, in fact, even when people are put on ventilators, in the US, we know that I think between 19 to 30% of people are able to survive. In the US, we don't know how it will play out in Africa and, of course, in Ghana. So I think that we may want to gradually move from this peaking notion and rather be stressing on the heavy precautionary or preventive measures we have always been recommending, i.e. the washing of hands, change in our attitudes. And I call most of these things individual gestures, because if you have to wear that mask, then it is up to you. The government can actually institute a regulation or a policy that everybody should be in a nose mask. But then as an individual, you've got to realize that, look, once you wear that nose mask, you are not really even protecting yourself, but you're actually protecting the other person. So that when I also wear my nose mask, then, or when you also wear your nose mask, then you're also protecting me. Then the bit about the social distancing, we've got to realize that, look, if we don't adhere to physical distancing, then chances are that you go into social isolation. So we may, of course, want to gradually move from this I don't know whether we'll call it a myth that we have peaked, because even after we claimed to have peaked, now look at the numbers we are reporting. And Evans, the interesting thing is that whenever we test, we find. So the best strategy is to test. But then, like I said, there's a limit to which you can test, especially when you have limited resources. And of course, you may even want to hoard some of your resources for a rainy day, because you don't want a situation whereby at a point in time, the important, not the important, but then the critical people who would need testing may not even end up getting those testing. So we may want to re-strategize. I mean, of course, even though quite a number of our the positive cases we are seeing, they are asymptomatic, do we just want to allow them to run around, walk about? I think this is where these heavy precautionary or preventive measures would or may need to be enforced, reinforced, so that our people understand that, look, we haven't peaked, and even if we have peaked, the virus is still in the country. And the amazing thing is, I call this virus a smart virus. Even though it is a smart virus, you really need very, very simple preventive ways to enable you not halt the transmission of the virus, but then limit the spread of the virus. So I don't think we have peaked. I mean, we haven't.
Dr. Betta, what's your take on this?
Yeah, I also agree, because for you to peak, it means you've reached your maximum number of cases, and the rate at which your numbers are decreasing is increasing, meaning you have a curve, and now your numbers are decreasing at a fast rate. But if we report 533 within one day, of course, we understand that it's from April, then clearly we have not peaked. And if you declare a peak, it goes with certain implications. A peak means that now we're getting less cases, so we're about to ease our non-pharmacological interventions, like people can go back to school, they can go back to church. So a declaration of a peak has policy implications that go with it. And I also believe that maybe we're not seeing as many numbers, because you have to remember, Ghana, I mean, we are a population that we take a long time to come to the hospital. I mean, if I remember clearly, even patients with breast cancer, they would wait until the breast is dropping and the cancer is burst out of the skin, compared to a lot before they show up at a hospital, compared to most places that as soon as they feel something in the breast, there's access to multiple physicians. You have to remember that we're dealing with few physicians for a 30 million population. And so part of that low numbers could just be that people, I mean, most people in Ghana, most people don't go to the hospital with a headache. They will just head over to the pharmacy and get some Tylenol. A lot of people believe their pharmacists are their doctors. And so maybe we should be asking the pharmacists the type of complaints they're actually getting at the various pharmacies. We don't go to hospitals for headaches. So we may be not detecting a lot of cases. And when it comes to our recovery, you realize that every country measures recovery differently. Some people just go clinically, like in the United Kingdom, nobody's testing anybody after you had the infection. You're just done, and even nurses are asked to go back to work after 1 week. But we're finding in the US and other places that test that, well, some people carry the virus in their throats for up to 40 days. So a country like that will not declare a recovery. So we have to look at what we're using to measure recovery to say that maybe we're not recovering as much. And so long as there are outbreaks occurring in factories, we should be looking at all these overcrowding areas before we declare that, you know, we've reached the peak and we're recovering. And when you ask me about the criterion to use, I'll just list them again. Number one, you should have evidence of low transmission, meaning your R0 should be about 1. 2, you should have the ability to detect every case as soon as possible so that you contain it. 3, you should be able to manage all your cases very, very well. And 4, you must have what the previous speaker was talking about, individual behavior, and then community engagement. Everybody from the child, like the 8-year-old I mentioned in smallpox, the students, everybody must understand. But whereby you have people still insisting that virus no cry and I mean, all those little talks that's still going on in various parts of the world. In Ghana, it means that we still have quite a bit of work to do before we can declare that, you know, we've reached the stage where we can start easing things and going out of our lockdown.
So that is Dr. Betta Aye's roadmap to lifting the rest of the restrictions. I'm going to take a break. When I return, I'll bring in my other guest on whether they agree those are the indications we need to see before we lift the rest of the restrictions that are in place. But the question also is, if what Dr. Betta Aye is pitching is the roadmap we need to look at, I still haven't heard what our R is as a country. I mean, I haven't heard that yet. In all the statistics that have been put out there, I don't know what Ghana's R is. Do we have the data to make the decision to lift the rest of the restrictions? And if we don't, how do we get it? And then also, the hard question that most of you are thinking about also, I need to ask. People look at the numbers and say, aren't we overreacting here? I mean, I walk through town, there seems to be nothing happening. I mean, 22 people dead. I mean, malaria kills far more people. Road accidents kill far more people. Aren't we overreacting? Simply open up the churches so we can go. We'll talk about that when we return. Stay with me. Just live on PM Express tonight, a conversation about the roadmap to lifting the rest of the restrictions so we can all come back to our normal lives. And just before the break, Dr. Betta Aye was laying out for us what she believes is what the roadmap should be, the indicators that will tell us when is the right time is to lift the rest of the restrictions. I want to bring in Dr. BEDIAKO on that question. The number one item on Dr. Betta Aye's list is the R value. That is I've just been checking this on the World Health Organization website. It appears to be possibly the most important thing you're going to be looking at. The number of people that one infected person will pass the virus on to on an average. So very important number, the R value. Do we know what our R value is in Ghana?
Sorry, there you go. As far as I know, we don't know what the R value is. We should. I mean, I think that is a question for the epidemiologists and statisticians at the Ghana Health Service. Certainly, that data should be available to them. I think we need to focus less on the number of cases and more on modeling our data. So, you know, there was a curve shown for the now infamous peak announcement. And, you know, it was just a curve showing number of cases over time. Really what we should be doing is when you look, you know, I'm not an epidemiologist, Prof might correct me, but my understanding is when you look at this sort of data, what you try to do is build statistical models and epidemiological models that explain the data. because when you look at individual days, there's a certain amount of error and variation. So if you just plot a line over your individual points, it doesn't quite capture the full depth of your data. So I think what we need to, I think now we have enough cases that we can begin to properly model the data, which will include calculating actually not the R naught, but the effective R. So R naught is sort of fixed for the virus. It's assuming that the virus is going to move through a population and no one is immune. But over time, as people become exposed, we expect that some people will acquire some immunity. And of course, through our mitigation strategies that the president has laid out, the controls that we've done, we are reducing the R. So actually what is even more important in our case is the RE, which is the effective reproductive rate, which is basically the reproductive rate at any time, considering the sort of the environment, the circumstances surrounding us. And I think that is what we need to try to get to as low, if not below 1, before we begin to talk about a peak. You know, the idea of a peak is sort of something you look back on and say, oh, on this day we peaked, but it really means nothing. You know, you could have peaked, but your R is still 1.5. That's still no time to celebrate. So what we really should be trying to calculate, and I hope that will come about, is we begin to take all the data we have so far, even with the backlog. You can go to the time when the sample was taken, and I believe the Ghana Health Service has begun to do that. And I think we need to model the data, calculate statistics such as the R naught and the RE, and then begin to see how is the trend going. Are we going up? Are we going down? And that will hopefully begin to inform the decisions that we make going forward regarding restrictions, lifting or imposing new restrictions. Let
me bring in Dr. Silva King on that. Doc, you are the virologist here with us. Tell me, do you have any idea, because you are also at KNUSC, KCC, are aware that testing is happening. Do we know what this, of course, Dr. BEDIAKO now introduces the other one, the RE is. Do we know what our RE is?
So we don't know the R naught, we don't know the RE. Sometime in April,
but that is
we tried.
Is it not? That is pretty heartbreaking, because if that is the #1 most important factor to determining whether to lift the restrictions or not, and we are several months in and we still don't know, then we are pretty flying blind here.
So we tried calculating the R naught. We had something around 1.67, but then we even had to collate data from several sites. And currently, I know that the Ghana Academy of Art and Science, they've put together experts. So they are doing the modeling, they are doing the predictions and all those things. So I'm sure very soon we'll be able to get to know our R naught. I mean, the R naught is always very, very important, because we know that countries such as Germany, even before they decided to lift the ban on restrictions, their R naught was around 0.4. There's no way you find 0.5 for human beings. So meaning that it was very, very, very low. But of course, once they decided to lift the ban on the restrictions, now they are hovering around 1. So for us, we don't know, unfortunately, but we are all looking forward to this expert group working so very hard. I know that the Ghana Health Service, they've already given them some data, and people are working day in and day out, and very soon we'll be able to come up with our R naught. I mean, not just the R naught, but other predictive values or factors.
I think, Professor KWEKU, your thoughts on this?
Yes, I think Dr. BEDIAKO and Augusta have made a point. The R naught is very key. We need it to determine whether we are getting to the peak or not. And besides that, the effective R also is needed. And we need good data to do that. The data we have collected so far, which is with the Ghana Health Service, I believe the dates of the data collection or sample collection were written. And so they can actually sort out the data and use that to do the modeling and then the calculation of the R naught and the effective R will also be determined when we start collecting incidence data. That's from now onwards on daily basis. We need to get all the cases in a day, and then we'll look at the incidents. How many new cases are we getting in a day? And that is what will help us to also determine the effective we will wait for the experts who have been put together to calculate that for us. But before that comes, we also need to put other measures in place because we have to ensure that all cases report, or we find all cases. Just like Dr. Betta said, in Ghana, we find it difficult to report until we are overwhelmed before we report. So it will be difficult for us to just sit down and say people should report. If we are not able to do active case search to get the cases, then we may be underreporting. And yes, and if we are underreporting, it means whatever we will calculate for our R or when we will determine our pay, we may have to come back and there will be a resurgence. So we need to actually get all the cases. How do we get them? The people need to be aware. They need to know. So far, education about COVID-19 in Ghana is very low and is very poor. The people are not aware of the government measures being put in place. What I mean by they are not aware is that they don't really understand why those measures are put in place. They say we shouldn't go to church. So they are just praying in 2 weeks' time, we'll start going to church. But why are we not to go to church? Why are we not to go to school? Why are we not to organize grand funerals? People don't understand. Education is not there. We need to really educate our people to understand. Even people don't really understand why we should wash hands frequently. And even knowing how to wash hands properly is another issue altogether. We sit on radio, TV, and talk about wash hands with soap and running water. But if we ask anybody to demonstrate, maybe it's only school children who can demonstrate to us because they are taught in school, but they are not able to practice at home because parents themselves don't know how to do it. So there is no enabling environment for the children to also practice proper hand washing. We need to understand why we should wash hands. Why should we wear nose masks?
Yeah.
What are we preventing? All these things need to be made clear. The people must understand it. Currently, I think the education, if any is going on at all, is mainly in the epicenters, Kumasi, Accra. What about the regions?
Yeah, I mean,
NCP went around with the vans, and then they were just talking and moving. So one person in the house will hear that wash hands, and another will hear that don't shake hands. So the information is not well coordinated. The people don't understand why those measures are put in place. And until that is done, we will not have to be thinking of lifting some of these restrictions.
Bans. So I think there's consensus around the table tonight that we are not ready to lift the remaining restrictions. The president, by the way, says the restrictions are going to be in place until 31st of May. Dr. Silva King, tell me, if you look into the crystal ball, looking at the data that we have, if you look down to 31st, what would it take for us to be ready on 31st to say we are at least lifting some of the restrictions? We've talked about the R already and where it needs to be for us to get to a point where we're lifting it. And the question is whether we can even hit the appropriate R to lift. But if you look in the crystal ball, is there any chance for those who are hoping and praying that the restrictions are lifted. Is there any chance that on the 31st of May and beyond, at least some of this will go?
I don't want to be a prophetess of doom, but we have to be very candid and very, very real. I mean, looking at our behavior, our attitudes, I honestly doubt. I mean, I foresee an extension of this particular ban, because we are not doing what we are expected to be doing. And like Prof KWEKU said, I mean, I have always said that, look, we are giving out a lot of information. We are not giving out education, because if you are only telling me wash your hands, you need to tell me why I need to be washing my hands. So I honestly don't foresee us going back to church anytime soon. We can still be doing the online church activities. We can still be doing meeting in smaller groups, no gathering, because look, this virus, it doesn't work. Human beings will always shift it or work with it and end up transmitting it. So I don't think we are anywhere near lifting up these restrictions. If you go back to the Ghana Health Service website, for example, we see that for 3 regions, they still haven't yet recorded any cases. Yes. But I think we may even want to look into that. Chances, I mean, we have this hotline. There's a hotline in place. I don't know whether we are already looking into the call logs, for example, to see where a lot of the calls are coming from. Of course, the health-seeking behavior of people like Bertha and Prof KWEKU, they have elucidated, is also a big challenge in our country. And even a strict adherence to all the mitigation measures we have been recommending all the time. I don't know whether people are honestly adhering to these measures. So for me, I don't foresee us going back to our normal lives anytime soon. And the health minister actually said that, look, chances are that this virus would stay with us for quite a while.
True.
And if we don't implement all the things we have been voicing out on daily basis, recommending, preaching, I don't think we'll be able to go back to our normal lives anytime soon.
But those are difficult words to hear, and because we're all looking forward to 31st, and the expert says, well, listen, I mean, we are not there yet. But Dr. Bertha, tell me something. This is a question that my friends, when we meet and we talk, it comes up, and I know many Ghanaians are thinking about this also. That, listen, aren't we going to look back now and say we are overreacting here? Because really, look at Ghana. I mean, 4,700 cases, 22 deaths. I mean, almost 500 recoveries. I mean, our health system is not overwhelmed. Life is normal if you walk on and drive on the streets. And now I'm hearing that the 1st may be extended as well. Isn't that overreaction here? Shouldn't you just go about living our lives?
No, we shouldn't. Like I said before in your program, anytime you are actually, people say you are overreacting, you're actually behind the power curve. And so, you know, we don't have to forget that what we're experiencing is not a Ghanaian thing. It's a pandemic. And the pandemic that closely mimics it is one that occurred exactly about 100 years ago, 1918 to 1919. It was about a few months before the end of World War II, where everybody was at war. And so you had lots of soldiers gathered together. And it actually came through Ghana, Sierra Leone, West Africa. This time it was through ships. And Ghana experienced that same pandemic. And I don't think we kept a lot of records. So the world has forgotten. That pandemic had the same R0 2.5. It killed 50 million people around the world. Over 500 million people were infected.